This is Professor Grodman, and this is a audio tape, hopefully getting on YouTube, pertaining to abnormal psychology. My best wishes to everyone. You guys are probably a bit papered out. At this point, you've done a personality disorder paper for me, as well as, of course, your research paper and exam one. Um, at this point in the semester, this is now April 12th as of the taping of this. I am going to present a brief lecture on schizophrenia on this audio and attempt to, by next week, the latest, have a couple of more audios, or at least one more audio. Actually, I think one more lengthy audio pertaining to chapter 14, 15, and 16. 14 dealing with cognitive, I think it's developmental, 14, 15 cognitive disorders, and applied aspects of psychology and the law, or ethics, really more ethics. That's chapter 16. From that, I would say the next 2 weeks, the latest, probably the week, sometime after I post it, or shortly after I post it, we will have a paper slash exam on that, more of a fill in the blank type thing. Maybe you'll have to list some things. Nothing lengthy in terms of writing. It gets difficult for both you as the student and for me as a first time quasi online instructor to grade at this point hundreds and hundreds of papers. So I've got to make it a bit more streamlined, hence this method of teaching and of assessment as well. Okay, so we're going to talk about schizophrenia, and we've talked about this somewhat in terms of our discussion of clinical assessment, and how doing a clinical interview one would evaluate if someone was experiencing or exhibiting signs of a mental illness, including schizophrenia. The two most prominent symptoms of schizophrenia are hallucinations and or delusions. Hallucinations, as you may recall, are sensory processes that other people do not have, that are unrelated to a medical condition. So, for example, if you were hearing things or seeing things, those are the two most common hallucinations. They connect to the five senses. And experiencing something unique like that, but it was related to a high fever or some other medical condition or even drug, that is not considered schizophrenia. Schizophrenia is an organic condition in which these symptoms, hallucinations, or delusions are grossly distorted belief systems. For example, there's no evidence the FBI would ever, look into your situation or tape you, and you think that you're being taped. It is more than just a paranoid experience, more than just paranoid in flavor. There is a psychotic element, and that's essentially what hallucinations and or delusions are. They're both related to psychosis, a loss of touch with reality. In the case of delusions, it is not sensory based; it's belief based, and it is a confabulation, an extreme distortion in reality testing, and it is biological in nature, and we'll talk more about etiology as we go on. So those two, hallucinations and delusions, are the two most prominent symptoms of schizophrenia. There are some secondary symptoms. Not everyone has all of these symptoms. In fact, some people, there is something called delusional disorder, in which it is largely just a delusion, not to minimize the seriousness or severity of that, but that the secondary symptoms are really not a part of that. So it depends on what is known as the subtype of schizophrenia, which we'll also talk about. So what are these secondary symptoms? Examples include things like social withdrawal, lack of motivation, poor hygiene. That's usually more associated with more severe subtypes of schizophrenia. Tangential thinking, where you go from topic to topic without any connection at all. Flat affect, which is sort of like you just are almost expressionless. So these are some of the secondary characteristics or symptoms of schizophrenia. How common is it? About 1 to 2% of the population, equally represented in terms of men and women. And it actually crosses all demographic categories, all walks of life. Age of onset is a critical component or feature, typically 18 to 40. Childhood schizophrenia is very rare, and the earlier it tends to manifest, the more severe and the more disabling, it typically is worse the prognosis. So if one gets it at 14, usually the prognosis is worse than 40. Women actually tend to become symptomatic older or later than men. Men tend to be earlier in terms of the expression of and experience of these symptoms, and it is as a result, it tends to follow a more severe course with men. There is a speaking of course, there is a course to schizophrenia. There are something called prodromal symptoms. These are things that are occurring before the person really develops full-fledged schizophrenia. They have not yet become delusional or hallucinatory, sometimes called psychosis, but there is a period of time that passes, probably varies from person to person. But eventually, if that leads to a psychosis or a psychotic episode or breakdown with hallucinations and or delusions, that's the active phase. Thanks to medication and improvements in other therapies, psychotherapy, more people are not chronically active. They do have what's known as a residual. They have residual symptoms. They're not quite as motivated as they once were, or don't feel as optimistic or as energized, but yet they're not primarily symptomatic. They're no longer hallucinatory or delusional. This is called the residual phase. The etiology is like most things. It's some complex combination of nature-nurture. One's learning history, nurture, on top of certainly a biological predisposition, a diathesis. We've talked about this, a diathesis. And actually, I just misspoke a little bit a second ago about like most things, because it is exceptional because you need to have this diathesis to become symptomatic with schizophrenia. That's not true, for example, with depression. You could have a terrible life event and at 50 have a major depression that you've never had before, ever in your life, and that's primarily externally or exogenously influenced. Whereas schizophrenia, the biological diathesis is a big deal. You have to have that in place. And even the stressor doesn't have to be as severe as you might expect. So, but it is a combination of nature-nurture in this way. There are, as I mentioned or alluded to before, different subtypes. There is something called, they used to call it paranoid schizophrenia, now they call it delusional disorder, in which the person has these psychotic delusions, but otherwise presents, it's a big otherwise. Anyway, the other characteristics of it are not very prominent, but or evident, but the primary symptom or symptoms are to deal with extreme paranoia, delusional paranoia. And actually they present okay, except in terms of if you were to speak to someone like this, they would look pretty conventional, except unfortunately the psychotic nature of their delusional thinking is highly problematic. Some people with schizophrenia have depression and psychosis. This is often referred to as schizoaffective disorder. And it looks a lot like bipolar disorder, except there are not these mood changes and mood swings. It's just depression. It's not depression and mania that you'd find in bipolar disorder. More severe types include disorganized schizophrenia, where a person's thinking is very disordered. Their ability to present in a coherent manner is affected. They go from topic to topic, the tangential thinking referred to before. They tend to have poorer hygiene. They're slovenly. It's more evident that they have a mental illness. Actually, the most severe form or subtype of schizophrenia is catatonia or catatonic schizophrenia, in which there are periods of great immobility followed by frenetic movement. That's a rare subtype. So these are some of the subtypes of schizophrenia. A theory, just to sort of get back into talk a little bit about the theoretical aspects of schizophrenia. Besides what's known as the dopamine hypothesis, which actually I'm jumping a little ahead. I'll get to that in a second. That deals with the biochemical, which we did sort of allude to. But another theory that is more external and more or less biological is that one of the things that happens with schizophrenia after it manifests, is that the person is more prone to socioeconomic decline because of difficulty with securing or maintaining employment. So this is sometimes referred to as a downward drift hypothesis. Just a point regarding that. In terms of etiology or causes, I just mentioned dopamine, and we also talked about having a predisposition. It really has to do with biochemically having an excess of dopamine and a deficiency of another neurotransmitter called serotonin. So that plus stress will often activate the disease somewhere between 18 and 40, most typically. Many problems associated with schizophrenia. One has to do with just physical longevity or mortality, that the average age of someone who, lifespan of someone with schizophrenia is not as long. It's considerably less than the average person in the population. 78 or thereabouts is the lifespan, the average lifespan for an American. For people with this mental illness, it's considerably less, probably 15 years or more, less than that. And a couple of reasons: side effects of medications, which we haven't talked yet about, but there are significant side effects which create weight gain and associated issues with health, heart disease, cancer, stroke. Poor access to health care, fewer social supports. These are among the reasons why people don't live as long. Chronic stress. The treatment. Well, the treatment in a very simplistic way is psychotherapy and medication. Some therapies are really not indicated or contraindicated, like anything psychoanalytic or insight-oriented. Therapies tend to be more surfacey in helping that person, encouraging them, sometimes referred to as supportive therapy, helping them change behavior, maybe some aspects of thinking. This would tie into cognitive behavioral therapy, along with certainly medication. Antipsychotic medication, the actual category today, is referred to as atypical neuroleptics. And these meds reduce dopamine and increase serotonin levels to reduce many of the aforementioned symptoms, particularly hallucinations or delusions. The contemporary research that actually some of it is not just specific to American culture or American research, is that there is a good deal of hope about psychosocial supports being really important and being critical to the success or the quality of someone's life with schizophrenia. That people who work in jobs that are realistic, that are not overly stressful, but provide structure and meaning and a 9 to 5, which is good for all of us, seem to be helpful in terms of the maintaining and enhancing even the quality of life for someone who has been diagnosed with schizophrenia. So there are definitely indications that certainly how you live your life matters. Having supports, having maybe being part of a system that is comprehensive, that is a mental health, getting mental health treatment, psychiatry part of that, psychotherapy, but along with that maybe some job training or job support, housing support. That sort of comprehensive program has a lot of efficacy. They've actually done some research in Australia and have found that if people have these sort of safe, I know there's a term for it, it's sort of the equivalent of a safe haven. If they can go to a place and talk and sort of get that support and encouragement and reduce the level of stress in their life, their reliance on medication decreases significantly. This is not to negate the importance of medications. We are talking about biological conditions in good part, but lifestyle and environment matters. It's not simply a medication treatment alone. It really does involve other factors and other treatment approaches. So that seems to be sort of where the contemporary research is going. People with schizophrenia do go into psychotherapy. One has to be supportive of them. Supportive therapy is helpful. Also, part of it I didn't mention is that part of the model of helping someone is, as we said, I mentioned, it's sort of vocational, it's housing, it's mental health. It also is what's known as psychoeducation, that you would if the person doesn't have sort of that knowledge, although they may, especially given sort of the resources of today, but you might educate them or as to the symptoms and the triggers, and sort of outline that in a much more intellectual way. But that can be helpful. So that piece of psychoeducation, just add that on to the treatment. Okay, I think that just sort of ends our discussion, or we're just about to the end. We talked about prominent symptoms, secondary symptoms, the incidence of it, the age of onset, something about etiology. We mentioned, remember, the theory of downward drift. Talked about schizophrenia and its effect on longevity. Some aspects of treatment, psychotherapy and meds, and some more contemporary research. As I indicated before, your next assignment beyond this will be involving the remaining chapters, 14, 15, and 16, and I'll be addressing some key diagnoses and points to each of these chapters, particularly 14 and 15, that deal with cognitive and developmental disorders. And you'll get a video, or rather an audio, pertaining to that as well. And at some point toward the end of this month, I would guess, I'm going to put this audio on, as I think I mentioned, about in a week or so. Today's the 12th of April. And sometime probably around the 25th or so, you'll get you'll have some sort of paper/exam, probably more like an exam, but more fill in the blank type again, that deals with each of these chapters: schizophrenia, developmental disorders, cognitive disorders, and the last one dealing with applied aspects. But sort of synthesizing this a bit and focusing in on honing in on certain diagnostic categories or diagnostic terms pertaining to this information and material. We're not going to go through every single one, but we'll sort of highlight some and give you a pretty good sense. So I hope everyone is doing well, and this, I assume, will get on YouTube and assist you in your preparation for your next assignment. I've been reading your research papers, by the way. They are looking good. Keep on sending them to me, and we'll hear from you either by email or phone soon. Don't hesitate to use either phone. If it's really urgent, please call. All right. Bye-bye.